So I think in this case, what we see is a patient who's had a good response to therapy. I say that because after the completion of her frontline approach, she did not have overt evidence of progression. And sometimes we have a better signal than this because the patients are left with disease that we monitor, and after the completion of their therapy, the disease is gone. So that's kind of a clear signal that disease was there, disease is gone, the treatment had an effect. In this scenario, the patient was left with no visible residual disease, and she was given 3 weekly paclitaxel and carboplatin. And in that time period of while she was on therapy, no new disease occurred. She didn't develop ascites. There was no new masses. So at the end of the primary assessment, we found that she was considered clinically NED. But whether or not she was actually sensitive or responsive to platinum is really not known because you don't have a marker. So as we see in this case, just about 4 to 5 months after she completed therapy, while we were observing her CA-125 and having her coming in for serial exams, she noticed some new symptoms. The symptoms were familiar. That's always a problem, and patients are very acutely aware of this. So these symptoms were familiar because they were associated with when she was diagnosed. So she promptly presented to her physician. They examined her, drew a CA-125, and noticed that it had gone from where her nadir was, which was at a normal level, to a very elevated level. And of course, then identifying the disease on re-imaging was a disappointing, but not unexpected, entirely unexpected finding in this disease. This patient has, on distribution of the disease by her CAT scan, is in areas that she had had disease before. This is probably a result of many factors, but one of the things, the aspects of this disease that we're trying very hard to understand is what's the role of the stem cell population that would necessarily, the cancer stem cell population that would necessarily be resident after the completion of therapy. And so I guess it's not so uncommon to see that these would recur in a similar area because that's where you'd expect these kinds of tumor cells to still be deposited. So in this case, she has this disease occur, and the fact that it occurred 5 months in a way that can be measurable would suggest that the tumors were probably growing even though she was still on therapy. It takes time for a human cancer cell to divide and for enough of them to divide to become measurable. And in this case now, the patient presents with relatively large amounts of disease after a relatively short period of time. This is outside of what we would consider the usual outcome, but it's unfortunately something we do see in about a quarter of the patients. So if you look at studies to see what population outcomes are from frontline therapy, especially ones that have an R0 resection like this patient had, you would have said that it was likely 50% or better that she would have a progression-free survival of 16, 18 months, maybe even longer. So that's kind of the bell-shaped curve. And so for someone to recur within a 5-month window after completing frontline therapy, especially with no evidence of disease at that time, would suggest that the biology of this tumor is somewhat different than those other patients. And that speaks to the slightly unusual aspect of this case, having her present at such a short period of time after completion of treatment. So the question as to whether or not BRCA mutation would alter the form of therapy. I think the short answer to that is probably not at this point. But it does raise a number of really interesting questions. So one of the questions, and I think one of the aspects of BRCA mutation that we had understood before was that these patients in general as a population did very well. Their life expectancies were longer, and their responsiveness to platinum was better than what we saw in the general population. And for many, there was this thought that maybe platinum sensitivity was a surrogate for BRCA mutation or dysfunction, so that these agents that were targeting towards the BRCA patients, the PARP inhibitors, might be, we could use platinum sensitivity as a surrogate for that. But here we have a case of a woman who had actually very good surgery, and she had a relatively short time to develop bulky disease. So the sense of whether or not she's platinum sensitivity and whether or not it's a surrogate for BRCA function probably doesn't really strongly exist in her. It doesn't necessarily mean that I wouldn't use it. I just probably wouldn't use it at this point directly. And the concept there is that if the tumor was vulnerable because it had lacked this functioning BRCA genes, we would have expected the frontline setting to be much more positive than it was. And so one aspect, I think, in understanding why it didn't respond as well would go back to try to understand what is happening in the microenvironment in that tumor cell that actually is making it not sensitive to the platinum. And so, you know, she's not had a lot of exposure to chemotherapy to actually induce what we would be considering probably, an aspect like reversion mutation in the tumor. So that's why I wouldn't necessarily exclude it. I just probably wouldn't use it right away. And I would tuck that away maybe at a later point when I might want to use it as a form of therapy.